Hello, welcome to my introduction to rheumatology talks. I've been a rheumatologist in practice for over 30 years, and during that time I've had the opportunity to give lectures to sophomore medical students in their Introduction to Medicine course on rheumatology. That's the basis for the lectures that I'm going to give. I've tried to avoid using jargon as much as possible when I made these, but occasionally I may use a word that I don't explain well. If I do, just feel free to look it up. The word could be typed into Google and you can generally find the meaning of it. The lectures will be posted in the order in which I made them, although many times they'll stand by themselves, so one doesn't necessarily need to watch all of them, and certainly you can pick and choose which talks might be of interest to you. I hope this is helpful to you and informative, and I hope that you learn something. Thank you for listening to my talks.
Hello. Today we will be talking about systemic lupus erythematosus. Specifically, I'm going to spend a lot of time talking about the pathogenesis, or how it occurs, a little bit about the cause of it. I will talk about what we see clinically, and that's where my experience is, how it's diagnosed, and just a touch about how it's treated. I'm not going to go into as much detail about treatment as I did for rheumatoid arthritis. Thank you for listening to me. I do apologize for the mispronunciations and the malaprops, etc. Sometimes my brain gets ahead of my speaking. So what is lupus? Basically, it's a chronic inflammatory disease whose cause is not known, that can affect the skin, joints, kidneys, lungs, the nervous system, the serous membranes, and other organs of the body. The patients with lupus develop distinct immunologic abnormalities, especially anti-nuclear antibodies. The disease is felt to be autoimmune, that is, the immune system's attacking the body. The clinical course can be characterized by periods of remission and exacerbation. They can sometimes have chronic or acute relapses. Genetic and environmental factors play a role in the pathogenesis. So, why do people get lupus? What's going on? And number one, we don't know for sure. There's various theories about what we're seeing in lupus. Number one, lupus may be an expression of common pathogenic mechanism initiated by a variety of factors. In other words, lots of things could set it off, but the final pathway is the same. Secondly, it may not even be a single disease. It may be a constellation of signs and symptoms that we've classified as a disease. The cause of the etiology is probably multifactorial, and we'll talk about that, and I listed some of the issues we'll talk on. However, as per our usual mantra with respect to autoimmune disease, we think there's a genetic basis and then something in the environment that kicks it off. Just a comment about nomenclature, I will be referring to this as lupus, or SLE. The actual name is systemic lupus erythematosus. There are other types of lupus primarily involving the skin, and we'll touch on those in a minute. So what are the clues that there is a genetic basis for lupus? First, in certain populations, in particular in the United States, non-Caucasian populations such as African Americans, Asians, Afro-Caribbeans, and people of Hispanic origin tend to have lupus in a greater number, or a greater percent, than the European American population. Secondly, certain HLA haplotypes are associated with this. We've discussed the HLA haplotypes in the past when we talked about rheumatoid arthritis. In particular, HLA-DR2 and HLA-DR3 tend to be more associated, but there's actually many that have been noted. We also talked about the STAT4 genetics or haplotypes when we talked about rheumatoid, and this also shows a greater incidence in patients with lupus. Certain complement deficiencies, which are genetically mediated, seem to be associated with a high risk for lupus. And in particular, I wrote deficiencies of C2 and C4 complement, complements used by the immune system to kill cells that it's trying to attack. In twin studies, there's a much higher concordance of identical twins in having lupus than fraternal twins. In other words, if they're identical twins, there's a much greater chance that they will have lupus. There's actually been over 100 gene loci associated or polymorphisms associated with lupus. And except for what they call the TREX1 mutation, there doesn't seem to be any single gene that singly increases the risk of lupus. However, in his paper, C.C. Mock and C.S. Lau state that it is estimated that at least 4 susceptibility genes are needed for the development of disease. Having said that, probably only about 20% of susceptibility for lupus is genetic. So what in the environment kicks it off? And again, we don't know for sure. There's several clues. First, there's thought to be possibly a virus start. One of the issues with lupus is these patients are producing all sorts of antibodies, and it's found that antibodies to certain viruses sometimes seem to be associated. So there's thought this may set it off. No virus in particular, however, has been isolated as a cause. Certain drugs have been associated with stimulating what we call a drug-induced lupus. In particular, procainamide and hydralazine seem to have a higher risk. There's some clues that possibly hair dyes can be associated with lupus. We talked about tobacco seemingly increase the incidence in rheumatoid arthritis, and it looks like that can occur in lupus also. And then I list UV light or ultraviolet light. It's been known for years that patients with lupus tend to flare in ultraviolet light, can get rashes, and it's thought possibly that sets it off. Now, women are affected more often than men with the disease. Now, the question is this genetic or not? And we'll talk about that. Or hormonal? Could it be hormonal? But just some statistics to support that. In the general population, only about 0.073% of the population has lupus, whereas in the female population, about 0.164% have lupus, whereas in the African American females, about 0.4% have lupus. So there is evidence that women are affected greater. The nurses' health study showed that women that have early menarche or have been treated with estrogen-containing therapies have an increased risk of lupus. However, there's been other studies that show no effect. As opposed to hormones, there could be a genetic factor or an epigenetic factor. Typically, one of the X chromosome is inactivated, and under the microscope we call those bar bodies. However, it's been found that in patients with lupus there tends to be more demethylation of the X chromosomes, so perhaps both X chromosomes are being expressed in the body, and this could possibly lead to antigens that could be perceived as non-self and cause autoimmune disease. So we talked about how there's a genetic predisposition in lupus and what some of the clues to that, and we talked about some of the environmental factors that may set it off, but the question is, how does that cause disease, and what's going on with the immune system? Well, what we believe is happening in lupus is that there's a loss of tolerance. And what I mean by that is normally the immune system needs to react to foreign antigens, foreign organisms, and not react to itself. And immunity is defined as a state of specific reactivity to a foreign substance, whereas tolerance is defined as a state of specific unresponsiveness to an antigen. And so it's important that we not react to ourselves. So it's a learned response to not react to oneself. Basically, the way immunoglobulins are formed is in ontogeny. There's a bunch of different genes coding for the immunoglobulins and different parts of the immunoglobulins, and these are sort of shuffled and put together, and lots of different antibodies are formed. And then while we're being formed, certain ones of these antibodies are selected out that are of self, and those B cells don't keep producing antibodies. But if there's a problem in ontogeny deleting either the self-reactive T lymphocyte clones or the auto-reactive B lymphocyte clones, one doesn't have tolerance. Another perhaps cause of loss of tolerance is that the T lymphocytes may respond to antigen, or as you recall, the T lymphocytes do respond to antigen only when presented with certain HLA haplotypes or major histocompatibility molecules. And if for some reason the major histocompatibility antigen is not quite right or perturbed, it may present a self antigen to the T cell such that the T cell recognizes as a foreign antigen, and that can cause loss of tolerance or autoimmunity. Another potential cause is the problem of this is a problem with apoptosis, and basically apoptosis is programmed cell death. Our cells in our body don't last forever, they're programmed to end after a certain period of time. Generally, those are cleaned away from the body without any inflammation by the macrophages. However, if for some reason there's a problem with the length of time that till the cell dies from normal, or if the antigen or the antigen presenting cell or the macrophage picks it up in a way that's not normal, it can actually, rather than just getting rid of the cell tissue of the dead cell, it can present it to the immune system and cause an immune response. This is a diagram by Mock and colleagues that just suggest possible pathways that can occur with the immune system and lupus, leading to the immune dysregulation and loss of function. And what they show is apoptotic cells presenting stuff to the macrophage or the antigen presenting cell, and for some reason that is then presented to the T cell, causing an immune response. Or cellular debris from the apoptotic cell is not cleaned away by the macrophage, and the immunoglobulins recognize it, and that can lead to an abnormal immune response. When that happens, then the B cell becomes activated and produces antibodies, and that then leads to the disease that we call lupus. The problem that we see in lupus is that tends to be centered more about the B lymphocyte and antibody production, much antibody production to self. This is, in a simplistic way, different than rheumatoid arthritis, where the autoimmune problem was more mediated by the cellular immunity or the T lymphocyte. Now, obviously, all arms of the immune system are involved in both rheumatoid and lupus, but again, immunoglobulins tend to be one of the big pathologic factors in lupus. So the next question is how does this cause damage in the body? And there's several mechanisms that have been noted. Number one, there's an immune complex disease, and specifically antigen-antibody complexes. The antigens, especially like in kidney disease, may be the DNA, and these are complexes of large complexes of antigen and antibody, and these can get lodged in the vessels. And we see this causing disease in the kidney. We see this causing disease in the skin. Another mechanism that lupus can cause disease is that there can be autoantibodies to cellular membranes. And in particular, we see this in things like the hemolytic anemia that it can occur, where the red cells are broken up, or when there's antibodies to the platelet membranes or the white blood cell membranes, so we can see a thrombocytopenia and a leukopenia. Antibodies to phospholipids can cause be associated with what we call lupus anticoagulants, and they're called anticoagulants, but actually, because when you do the lab test, the partial thromboplastin time, which is sort of a measure of coagulation, appears to be prolonged. However, in actuality, what happens functionally is actually increased clotting of the blood. And because of this, there's an increased risk of arterial thrombosis and things like stroke, increased risk of things like frequent miscarriages and stuff like that. Thirdly, there can be antibodies to certain cell constituents. And this is thought to be what causes what we call lupus cerebritis, where there's inflammation going on in the brain due to lupus. So we talked a bit about why we think people get lupus. We talked a bit about how the immune system is affected with lupus and how affecting the immune system causes disease. I now want to spend a bit of time just talking about what we see. Now, one of the problems with lupus is that it can present differently in different patients, and thus I'm going to go through a long sort of shopping list of different problems or ways that lupus can affect the body. But when we get to the diagnosis, well, the fact is not every patient has every condition or every symptom. Number one, a lot of times there's systemic manifestations, and most patients with lupus do have fatigue. Now the problem with fatigue is that if that's not a good what we call a pivot point about which to make a diagnostic or a differential diagnostic list, because anything or nothing can cause fatigue, but certainly patients with chronic inflammatory conditions can have fatigue. There can be weight loss associated with lupus, again signs that this is a systemic disease. They can have fevers. However, one thing to remember is that a very common cause, I shouldn't say as a common cause, but when there's death in a lupus patient, it's frequently due to infection more than it is the disease. So we can't forget that fever can mean more than just lupus. It can also mean infection. And then the patients can have morning stiffness, very much like an inflammatory arthritis, like rheumatoid arthritis. The patients can have an inflammatory arthritis that looks exactly like rheumatoid arthritis. And what I mean by that is when you do the exam, they have a swelling of these joints, like a synovitis, like we see in rheumatoid arthritis, involving very similar joints. However, the arthritis, and this is just an example, they can even get ulnar deviation. However, the arthritis is different than rheumatoid in that it's non-erosive. And I would submit that if you took an x-ray of this hand, whereas you may see ulnar deviation, one doesn't see the erosions of the joints like one does in lupus. When the synovial fluid is obtained, it is not as inflamed as in rheumatoid arthritis, and generally the synovial white counts in lupus-associated arthritis are less than 3,000. The skin can be involved in many different ways in lupus. Indeed, the skin is one of the hallmarks of how we describe the disease, and a lot of patients do have skin manifestations, although not all of them, and indeed a lot of patients in my practice have not had skin manifestations. Number one, the patients do have a sun sensitivity. Now this can cause a rash, as noted here. You notice that the rash is red, but it is sparing the nasolabial folds. Sometimes the sun sensitivity can be so great that they actually get a flare of disease. And in treating these patients, it's important to remind them that to be careful to avoid the sun, to wear sunscreen, to cover themselves during the high parts of the day. This is what we call a butterfly rash, and if you look, it looks sort of like the wings of a butterfly. This is also sometimes called the mask of the wolf. Lupus means wolf. That's where we got the name lupus. It's sort of red. That's where we got the name erythematosus, and if it's associated with systemic disease, systemic lupus erythematosus. They can sometimes get a macular-papular eruption. Now this looks sort of like a drug rash or maybe even a skin vasculitis, or leukocytoclastic vasculitis. This can be itchy or pruritic and can occur after exposure to the sun. This is what we call discoid lupus, and actually discoid lupus can occur by itself with skin involvement only, without systemic disease, or it can be a part of systemic disease. And what you see here is there's sort of a raised border to the rash, and there's central clearing of the rash. There's also hypopigmentation here. One of the problems with discoid lupus is that it's scarring, and indeed, as per this patient, it can be devastating, as one could imagine, to have scarring in this distribution on the face. This is subacute cutaneous lupus, and what we see here is sort of this sort of reddish rash. Skin's sort of scaly. It can sometimes look sort of like discoid lupus, although the prognosis is much better, doesn't cause scarring, or it can sometimes look like psoriasis. This is oral ulcerations. This can occur on either the hard or the soft palate, and they look pretty horrible actually, looking at them when you're looking at them. However, interestingly, a lot of the times the patients do not have symptoms associated with that. The patients can have hair loss or alopecia. It can occur in up to half the patients. They can either be diffuse or there can be patchy alopecia. Usually when it's going on at the onset, there is some scalp redness. There can be vasculitis associated. Vasculitis, again, is inflammation of the blood vessels. This is a little vasculitic nodule right here. This is a condition called livedo reticularis. You sort of see this fine lacy pattern, and we can see that associated with lupus, or we can see it associated with what we call cardiolipin antibodies or lupus anticoagulants, even if the patient doesn't have full systemic lupus erythematosus. These are splinter hemorrhages. They can occur with vasculitis. They can also occur with what called bacterial endocarditis. Endocarditis is an inflammation of the heart valves, and it can throw little clots out to the tissue. Or, like I say, this can occur with a vasculitis such as we see in systemic lupus. This is an Osler node. Again, that can occur with vasculitis, or it can occur with bacterial endocarditis. And this is fingertip necrosis. This can occur because of vasculitis causing complete loss of blood supply to this tissue, and the skin dies. We call it skin infarction, such as myocardial infarction. We call this a skin infarction. Now, the patients can also have inflammation of the lining of the heart and the lungs. We call it serositis. When it's the lining of the lung, which is called the pleura, it's a pleurisy, and what you see here is fluid in surrounding the lung. I would submit that there's probably pericardial fluid also, or pericarditis. The dimension of the heart in this picture is much greater than is normal. There's other lung involvement that can occur. They can have a pneumonitis. Sometimes it's just an inflammatory process like a pneumonia, or sometimes it can be scarring, and they can get permanent damage to their lungs associated with that. There can be heart involvement associated with lupus. We talked about pericarditis in the last slide, with the filling of the pericardial sac with fluid. This is what we call Liebensack's endocarditis, and basically that's this lesion that sits on the heart valve. This is a mitral valve. The mitral valve lies between the left atrium and the left ventricle, and you can see this this growth here on the valve next to what we call the chordae tendineae. A lot of times this is asymptomatic, but sometimes patients are at risk for getting secondary infection of this with a bacterial endocarditis, or sometimes this can even lead to needing to have the heart valve replaced. There can be other heart-associated involvements of lupus. They can have an inflammation of the heart muscle, which we call myocarditis. As with rheumatoid arthritis, there's an increased risk of coronary artery disease. And again, this occurs later in the course of the lupus. And lastly, they can sometimes have defects of the conduction pathways in the heart. There's a lot of hematologic manifestations associated with lupus. Number one, they can have an anemia of chronic disease. Whenever there's chronic inflammation or illness, and it's not just with lupus, the bone marrow may not be as efficient, and a lot of times we'll see a drop in hemoglobin. We did discuss that a bit with rheumatoid arthritis. We also talked about there can be antibodies to the cellular membrane causing a breakdown of the red cell, and when that happens, we have what we call a hemolytic anemia. That can likewise happen with the white blood cells causing a leukopenia or a lymphocytopenia, and likewise can happen with the platelets causing a thrombocytopenia. We talked about antiphospholipid antibodies, and we talked about how the lupus anticoagulant can actually prolong the partial thromboplastin time and look like the patient is anticoagulated, but they're actually hypercoagulable. Previous classification criteria for lupus used a false positive VDRL, Venereal Disease Research Laboratories. This is a syphilis test, and it's thought that's a phospholipid antibody. Or they can have cardiolipin antibodies, or more recently, anti-beta 2 glycoprotein antibodies have been associated with this. Again, these actually cause a hypercoagulability. The patients tend to have clots more easily, can have deep venous thrombosis, strokes, and what we call fetal wastage or miscarriages. As with rheumatoid arthritis, there can be an elevation of the sedimentation rate associated with the inflammation that we're seeing. Now, the kidney can be a very severe and dangerous manifestation of systemic lupus. It's suggested perhaps up to as many as 50% of patients with lupus have some sort of kidney involvement. It can be very mild with only mild protein or in the urine or proteinuria, or it can be very serious and leading to renal failure, dialysis, and possibly even death. It's recognized by checking the urinalysis and looking for the presence of protein, blood, and cellular casts. And if it's suspected, a kidney biopsy is required. There's several pathologic types. The first is mesangial, shown here, and that occurs in up to 24% of the patients. This tends to have a better prognosis. Proliferative occurs in, and what we see going on here is there's this proliferation in the glomeruli. The glomeruli is actually the filtering part of the kidney. If less than 50% of the glomeruli are involved, we call that focal proliferative, and if greater than 50%, we call that diffuse proliferative. This is very dangerous and actually can lead to kidney failure. Electron microscopy shows that there's immunoglobulins in the mesangium, and I have a better picture of that with an immunofluorescence study. And then membranous glomerulonephritis occurs in about 15% of the patients, and there's not a lot of cellular proliferation. There's just a lot of thickening of the glomerular basement membrane. And this is just an example of proliferative, and what this is an immunofluorescence of the kidney. Basically, it's a antibody against the antibody complexes, and you can see this sort of lights up. It's a fluorescein tagged antibody, so when it's looked at with a fluorescent microscope, it sort of lights up under microscopy. And again, just to show the difference, this is a proliferative versus normal. Notice how thick this appears here and how thin these are here. This is membranous, and again showing this is an electron microscopy of membranous glomerulonephritis, again showing a thickening of the glomerular basement membrane, GBM, again decreasing kidney function. And then another type of involvement that can occur is what we call tubulointerstitial, and this is more in the collecting part of the kidney. This can occur perhaps in up to 75% of patients. Next, let's discuss nervous system involvement with lupus. When it involves the brain, we call it lupus cerebritis. And the problem with lupus erythematosus is it can occur in lots of different ways, and that makes it very difficult to diagnose. It can be as simple as just headaches, and that obviously is very hard because there's many people have headaches for many reasons. Sometimes there can be psychological problems such as depression and anxiety, and again, it's hard to state whether that's an inflammation of the brain or just other more common causes. But things that are more remarkable is sometimes the patients can have psychosis. Now, this is an issue because it can occur either due to the disease or high doses of corticosteroids can cause psychosis. And we had talked about that when we talked about rheumatoid. Seizures can occur as a sign of lupus erythematosus. Sometimes patients can have organic brain syndromes, and this, in a way, looks like dementia. They have problems with their perception, memory, and intellectual function. Strokes can occur, although this probably happens more due to cardiolipin or antiphospholipid antibodies associated with hypercoagulability. Um, the peripheral nervous system can be involved also. They can sometimes have peripheral neuropathy, or the spinal cord can be involved with the transverse myelitis, and this can actually lead to a paralysis type of picture. Now, the problem with lupus erythematosus is it's hard to diagnose. A lot of times the double-stranded DNA, the serum complement levels, and immune complexes do not correlate with disease. A lot of times the cerebral spinal fluid is normal, and so one needs to look at it with other means of testing. PET scanning is sometimes used, MRI is sometimes used, but again, it's very difficult to diagnose. Now, other things that can occur with lupus, one is Raynaud's phenomena, and basically what this is that the digital arteries spasm and there's a decreased blood flow to the digits. And what one sees in Raynaud's is that the digit first will turn white. A lot of times there's a line of demarcation like you see here, but with time they can progress to blue, and then with reperfusion of the fingers turn red. It's the national colors, red, white, and blue. Patients can have muscle involvement. Generally it's not a frank inflammatory polymyositis, but they can have muscle pain. Lupus in pregnancy is a real challenge. Typically, with respect to our patients with lupus, we like to have the patients under good control of the disease if they want to get pregnant. One of the big problems with pregnancy is that many of our medicines are teratogenic. In other words, they can cause birth defects, so we want to have them under good control under few medicines during pregnancy. There's a large body of literature written discussing what happens to the patients during pregnancy, what things to watch for, etc. The cardiolipin antibodies and lupus anticoagulants can be associated with frequent miscarriages, and so we want to know if patients have those going into pregnancy. And we talked about how the SSA or Rho antibodies or SSB or Li antibodies, which sometimes are called the Sjogren's antibodies, can be associated with neonatal lupus, and that neonatal lupus can be manifest as either just a rash, or sometimes they can have heart involvement with a complete heart block, or sometimes even damage to the heart muscle. Now, this is avascular necrosis, and basically what that is that the blood vessels to the head of the femur for whatever reason decrease the blood flow to the head of the femur, and the head of the femur dies, necrosis, and what we see here in this picture is that it's actually flattened. Now, this could be due to either the disease, or a lot of times patients with lupus are on high doses of corticosteroids, and these also have been shown to be associated with avascular necrosis. I will now talk about the lab tests and special studies that we used in the evaluation and monitoring of systemic lupus. First, I want to talk about the anti-nuclear antibody. This is very highly associated with lupus. Basically, the anti-nuclear antibody is antibody in the serum to a nuclear antigen. And the way it is measured, one takes a cell substrate, classically mouse liver or kidney were used. However, more recently, human cell lines are used. And then a drop of the patient's serum is placed on a slide of that. Now, the serum is not undiluted. Typically, it's diluted in a ratio of 1 to 40, 1 to 80, 1 to 160, 1 to 320, etc. That's layered on the slide, and then the slide is washed, and if there's an antibody to the nucleus, it will attach. And then after the slide is washed, a fluorescein tagged rabbit antibody is layered on, and that is washed, and then it's looked at under a microscope with a fluorescent light source. And one gets pictures that look like this. Now, the way the study is interpreted is it's interpreted at the highest titer that a pattern can be seen. So typically one will see the ANA reported as a titer of 1 to 160 or 1 to 320. And unfortunately, what is significant in the lab is different from lab to lab at times. There's different patterns noted, and that's what you're seeing here is the different patterns. You have the peripheral pattern, you have the sort of the speckled pattern, you have the diffuse and the nucleolar pattern here, and we'll talk about what those mean. On human cell lines where there's active cell division on the slide, one can also get a centromere pattern. You don't see that on the mouse kidney or liver substrate, but again, we mentioned those are not really used that much anymore. And it's important, the centromere can be helpful because that suggests certain types of diseases. The ANA is felt to be about 95 to 99% sensitive for lupus. In other words, of 100 patients with lupus, at least 99 will have an ANA. And it's about 95% specific, which means about 5% of the population has an ANA. Now, the different patterns can be associated with other antibodies, and specifically we talk about diffuse. That can be associated with many of the autoimmune diseases, whereas a speckled pattern is associated with what we call extractable nuclear antigens, ENAs. These are things like the Sjogren's antibodies and stuff like that, and can be associated with things like lupus, rheumatoid, Sjogren's disease. Nucleolar antibodies, again, those are more often associated with progressive systemic sclerosis or scleroderma and Sjogren's. The peripheral is more often associated with the double-stranded DNA, and the double-stranded DNA is more specific for systemic lupus, SLE. And the centromere pattern, as we mentioned, is not on the mouse liver and is more often associated with crest variant scleroderma. Now, I just want to make a little comment about biostatistics here because I find that the ANA is incorrectly applied many times. It is not a very good screening tool. It's more useful in patients that autoimmune disease is found in order to classify them as lupus. And just a reminder of what sensitivity and specificity means. Sensitivity is the people with disease with a positive test over the total number of people that have the disease, or what we say is the true positive over the true positive plus the false negative. Specificity is the people who don't have the disease with a negative test over the total number of people who don't have the disease, and specificity is equal to the true negative over the true negative plus the false positive. Okay, so that's just the definition of those words. Now, using data we discuss, and I mentioned this briefly when we were talking about the genetics and the risk factors for lupus. We talked about the prevalence of lupus in the population, in the general population. So in the general population it's about 0.073%. In women it jumps to 0.164%, about twice that. And in African American women it jumps to 0.406%. So if you have 1,000 people that have systemic, or 1,000 people, if you take 1,000 people, the number of people in that population will be on the order of 1 in the general population, 2 in the female population, 4 in the African American women population. However, if we looked at the number of positive anti-nuclear antibodies, and these numbers are not right, but it's going to be about 50, and so it's going to be about 50%, or well, probably a little bit more in the population, 51% in the general, 52 in the women, 54 in the African American women. The probability of the patient having lupus, if they have a positive test, is at best 7.4% in the African American women. So this is not a good screening test, and unfortunately, in a way, I see that used. Patients present with fatigue, they get an ANA, or even fatigue and achiness with no frank arthritis, they get an ANA and it's positive, and they're referred to the rheumatologist, and of course we don't find lupus. Or patients that have a headache. Unfortunately, headaches can have many causes unless there's clues that it's due to an inflammation going on. Uh, Typically we find that most of the time patients that have an ANA and a headache do not have any evidence of lupus. The other point about the anti-nuclear antibody is that it is not helpful in following the disease. In other words, once the diagnosis of lupus is made, repeated ANAs doesn't tell us anything about the disease. Now let's talk about specific autoantibodies. These are not ordered unless the ANA is positive. First, let me talk about the double-stranded DNA. This is more specific for systemic lupus erythematosus and is helpful. We talked about the extractable nuclear antigens when we talked about the patterns, how they tend to be more often associated with the speckled pattern of the ANA. The SM antibody is more specific for lupus than the ANA. The RNP can be associated with a condition we call mixed connective tissue disease. Mixed connective tissue disease is a sort of a constellation of lupus and inflammatory myositis, polymyositis, or dermatomyositis, and or scleroderma. We talked about the Rho or the SSA and the La SSB Sjogren's antibodies and how they're more often associated with neonatal lupus. There can be non-nuclear antibodies, and we've already talked a bit about the cardiolipin antibodies and how they're associated with hypercoagulability. The VDRL, Venereal Disease Research Laboratory, a test for syphilis, a false positive test for syphilis has been associated, or one of the previous diagnostic criteria for lupus. Lupus anticoagulant and cardiolipin antibodies fit into this class, and the newest is the anti-beta 2 glycoprotein antibodies. Other labs that we watch, number 1 and 2 are the measures of inflammation, the erythrocyte sedimentation rate or the Westergren sedimentation rate, and the C-reactive protein. We talked about these also when we talked about rheumatoid disease. The complete blood counts are watched. Obviously these are of interest because we would like to see if there is a hemolytic anemia or a leukopenia or a thrombocytopenia. The urine is watched. The kidneys is a big issue in lupus, and we're watching for protein, cellular casts, red blood cells, any clues that there may be inflammation going on in the kidney. And the serum complements are watched, in particular C3 and C4 and CH50. The serum complements actually drop when there's increased activity of lupus. So we've talked about the sort of the constellation of things that can occur in systemic lupus. Now the question is, how do we make the diagnosis? And again, as we discussed in rheumatoid arthritis, I think it's important to consider the classification criteria. As I mentioned, classification criteria are not diagnostic criteria. Rather, they're used to agree that patients in a study all have a disease, so we can make sense of the results when that's done. So in 1982, a set of 11 criteria were proposed, and in order to classify one as having systemic lupus, one needed to have at least 4 of the 11 criteria. And I've listed them here. I'm going to go to the next slide, which these were revised a bit in 1997, and just sort of go through and talk about how those what we're looking for. So the first, of course, is malar rash. We talked about what that looks like, how it on the cheeks and spares the nasolabial fold, or a discoid rash, and we talked about how that can cause scarring, or photosensitivity, and again, that's a rash that occurs as a result of exposure to sunlight. We talked about the painless oral ulcers that can occur. We talked about the inflammatory arthritis that can look like rheumatoid, but it is not erosive. We talked about how there can be inflammation of the pleural lining or the pericardial lining. Renal disease. Now, the 1997 criteria just looked for proteinuria, and they're looking for greater than 0.5 grams per day. And I state that because when we look at the more recent criteria, they actually use biopsy information. We're looking for specific neurologic disorders, in other words, seizures or psychoses, so depression or headaches wouldn't work. We're looking for potential hematologic disorders such as a hemolytic anemia or leukopenia or lymphopenia or thrombocytopenia. We're looking for blood work such as a dsDNA, SM, or a phospholipid antibody such as a cardiolipin antibody, or false positive test for syphilis or a lupus anticoagulant. And we're looking at an ANA. Okay, so if what we're looking for is four of the 11 criteria. Now, the way I simplify that in my thinking, remember, lupus is an autoimmune disease that affects lots of different parts of the body. So what I'm looking for is evidence of autoimmunity in several different organ systems. Now, in 2019, the American College of Rheumatology, in conjunction with the European League Against Rheumatism, and this is a European body that's similar to the American College of Rheumatology, and indeed the meetings are both meetings are attended by many of the same people, work to come up with a new criteria. And what makes this different from the previous criteria is, number one, there's an entry requirement. In order to be classified for study, they expect people to have an ANA. Again, the ANA is very sensitive, probably about 99% sensitive, and so they felt patients they excluded, at least for the studies that did not have an ANA, that wasn't important for their studies. They weren't interested in what we call ANA negative lupus. And so if that was present, then they would then use a weighting scale in order to classify lupus. And in order to be classified as lupus for the study, they expected at least 10 points out of this scale. Now, what's interesting to me about this most recent scale is, number one, it includes serum complements, which we didn't have before. Joint involvement doesn't ask for frank arthritis. What they're asking for is if a patient has joint pain and morning stiffness, that was sufficient. But they also include criteria including a renal biopsy. And if the patient had a renal biopsy with a class 3 or 4 lupus nephritis, this would be focal proliferative or diffuse proliferative, they already have 10 points. So if they have an ANA and a appropriate biopsy, they would classify them as having systemic lupus. Now again, these are classification criteria for studies. Typically, we can make the diagnosis without these in order to treat. Most often in our patients, if they do not have an ANA, they will then have one of the Sjogren's antibodies, SSA or SSB, and then the other criteria for systemic lupus erythematosus. When making the diagnosis, we need to consider what other things can look like lupus. Usually the problem with the diagnosis of lupus isn't that they present to the rheumatologist with multi-system disease, which I'm going to talk about in a minute, but rather they present to other subspecialists, such as one presents to the neurologist with seizures or dementia or organic brain syndrome, or one may present to the dermatologist with a rash, or to the hematologist with a thrombocytopenia or hemolytic anemia, or to the nephrologist with a glomerulonephritis or an inflammation of the kidney. In those cases, it's important to think about, well, they have this disease in this organ. Can this be part of an all-over autoimmune disease such as a lupus? So that tends to be how we find lupus most often. Now, occasionally, or even when we do find lupus, it's important to consider other diseases that can affect can affect multiple other organ systems, and I just listed several of them here. We've already talked about endocarditis, which is inflammation of the heart valve, can be associated with things such as weight loss, fatigue. We talked about the splinter hemorrhages. They can sometimes have joint pain and stuff. Uh, Gonorrhea or gonococcus or meningiococcus can present with rash and arthritis, which looks like lupus. Serum sickness, which is a reaction to drugs, can present with a rash. We did show the rash and arthritis and sometimes kidney involvement. And this probably is an immune complex disease. Hematologic malignancies such as lymphoma or leukemia can look very much like lupus with joint pain and swelling, etc., weight loss. Thrombotic thrombocytopenic purpura can present with low platelet counts. Neurologic involvement, again, can look like a lupus. Sarcoid, which I hope to speak about in the future, can affect many different organ systems. Secondary syphilis, likewise, can present with multiple organ system involvement. Septicemia, which is infection spreading through the bloodstream, can present with fevers, rash, and multiple organ problems. One of the issues in lupus, and one of the high causes of death in lupus, is infection. And so even if one has a lupus and they're presenting with symptoms that can look like infection, other symptoms, that needs to be evaluated and ruled out. In other words, when you have a lupus, it's very important to consider septicemia. And then leprosy, likewise, can sometimes present with multi-organ involvement. So how do we treat this condition? And again, I'm just going to speak in generalities here. I'm not going to go into the painful detail I did with rheumatoid arthritis. I do think this is a subspecialty disease. Rest is very important for our patients. They need adequate rest and they need to avoid the sun. If it's a mild lupus with just maybe some joint pain and swelling, some rash, nonsteroidals, maybe nonsteroidal anti-inflammatory drugs such as ibuprofen, etc., can be a benefit. Corticosteroids are used frequently in lupus, and this can range from very low dose for mild manifestations such as arthritis, etc., to very high doses. We do use high doses in things like the hemolytic anemia or if there's brain involvement, and even in the initiation of therapy for things like the kidney disease. Now, the antimalarials, and these are things such as hydroxychloroquine, are felt to be very important in the treatment of lupus. For the patients with mild lupus, they are probably the treatment, and even patients with aggressive lupus where other medicines are used, it's felt that a course of antimalarials can benefit the patients, and so they're very frequently, almost always used in our patients. Cytotoxic drugs such as azathioprine, which we talked about with rheumatoid, or cyclophosphamide, which is actually an alkylating agent, which is a chemotherapy drug associated with all the bad side effects of chemotherapy, including hair loss and nausea and low blood counts, are very important in the treatment of lupus. Indeed, cyclophosphamide very much changed the outcomes in patients that have kidney involvement, such that we get very good outcomes with our patients with kidney involvement these days. Now, next I want to talk about mycophenolate. Mycophenolate has, I think, been a real game changer in the treatment of systemic lupus erythematosus. Basically, it functions by inhibiting the synthesis of the purine nucleotide guanosine. As you recall, the purines are important in the production of DNA and RNA, and I think guanosine is a monomer which is part of the backbone of RNA. And blocking the production of that, one blocks lymphocytic function, one decreases the proliferation of the B cells and the T lymphocytes, and one also decreases their immunoglobulin production. Having said that, this is much better tolerated than cyclophosphamide. The medicine in the past prior to the use in lupus was used for patients with transplants and has now taken a lead role in the management of severe lupus, in particular severe kidney disease. I like the medicine very much and I use it a lot in systemic lupus erythematosus. Rituximab is an anti-CD20 antibody and it's used to remove B lymphocytes. We talked about that in the treatment of rheumatoid disease. Theoretically, it makes sense that it would help lupus. However, I will say I've not been very impressed with the studies showing its benefit. However, you'll find it in a lot of treatment protocols for systemic lupus, in particular patients that have failed all of our other therapies. Belimumab or Benlysta is indicated for systemic lupus. It does inhibit B cell stimulation. Its indication in the past was primarily for non-renal lupus, which for my practice wasn't that important because I found I could usually control the disease if they didn't have renal involvement with other medicines. However, recently it's been shown to be useful in the treatment of lupus nephritis or kidney involvement in lupus when used with mycophenolate. So I think its use will be increasing and changing. There's another newer medicine out on the market now called anifrolumab or Sofnello, and this is a type 1 interferon receptor antagonist, and again it's not indicated for severe lupus nephritis or neuropsychiatric lupus, so we'll see what its role is. Other medicines, calcineurin inhibitors such as tacrolimus, eveclosporin, and cyclosporin are used primarily in the treatment of kidney disease later on if there's problems with response to things like the mycophenolate. So we talked a little bit about the disease. Now, the question is, how do I follow them and what's the prognosis? We talked a little bit. I typically see the patients on a very regular basis. I do a good exam. I wouldn't say complete because I don't do pelvics and stuff like that, but I do very good exam looking at the skin, feeling all the joints. Like I said, a rheumatologist squeezes joints, listening to the heart, lungs, and examining the abdomen. I follow the blood counts, follow the blood counts, the urine, the sed rate, and serum complements, looking for activity of disease. And we adjust our therapy. Generally, the prognosis is generally pretty good. I mean, it's not perfect. I hate to say we do have patients that don't respond well to therapy, but most of the times patients do well. Indeed, for me, it's been a very gratifying disease. I can remember several times going into a hospital room. The patient's has severe lupus and in fear of their life. And a year or two into the course, after we've treated for a while, we can sort of sit back and look back and laugh at those days, realizing the patient's doing well. With respect to complications of the disease, I think it's important to always remember and keep in mind that infection is an important cause of death in these patients and it needs to be watched for. In closing, I put up this Gary Larson slide. I always get a chuckle at it especially when I'm looking at a lupus patient, because I really do wish my patients would present this easily and that the diagnosis was easy. Thank you again for listening to me. If you made it all the way here to the end, the next discussion will be on osteoarthritis. Bye.
So that concludes this talk. I thank you very much, and there'll be further to follow.